Welcome to welcome to the Endeavor Health Outcomes Research, Health Equity, and Implementation Science Research Series. Today, we are honored to have Dr. Loren Saulsberry from the University of Chicago, who will be presenting on advancing genomics to improve health equity. We will also be joined by an expert panel, including Dr. Manolo Pereira from Northwestern, Dr. Lotte Planiapen from Stanford, and Dr. Mark Dunneberger from Endeavor Health. My name is Sean David. I am Program Director for Translational Science and Health Outcomes Research and Vice Chair for Research and Family Medicine at Endeavor Health and Clinical Professor at the University of Chicago. I am joined by Rachel Brewington, who is a facilitator for this seminar. And I'd like to just, first of all, start off by giving a shout out to all of those working on the front lines in the community and in the clinics to try to advance health equity. And thank you to the leadership of Endeavor Health and Dr. Susan Fisher, the Director of Health Outcomes Research, for supporting this seminar series. Our objectives for the seminar series are to disseminate research that advances the implementation of health equity in our health systems, health equity in our communities, policy change to promote equitable care and outcomes, and to advance translational science. And we want to also support clinical investigators by having an open network to have an incubator effect on new ideas, new collaborations, and cross-cutting research. So we're really encouraging team science, and this is an opportunity for people from different corners of different sectors of health and society to come together. We also want to connect researchers across metropolitan Chicagoland and the 6 institutions of our CTSA, as well as the CTSAs at Northwestern and University of Illinois, Chicago. And ultimately, we want to germinate outcomes research that shows improved patient and equitable community health outcomes as well. So the objectives of today's seminar are first to review the landscape of gaps and opportunities at the intersection of human genomics, genomic medicine, health equity research. And secondly, to discuss future considerations for advancing health equity in human genomics and genomic medicine. Today's seminar will highlight recommendations from National Human Genome Research Institute workshop that was done in 2002 and a Nature Medicine paper that Dr. Saulsberry and several luminaries in the field published last year on how to advance health equity through genomic medicine. And this really does hit on several different translational science principles, such as creativity, innovation, focusing on unmet needs, particularly in marginalized communities, generalizable solutions, team science, efficiency and speed by bringing people together with implementation science frameworks. And it does promote diversity, equity, inclusion, and accessibility for patients and citizen scientists and academic researchers. So we think this is a good example of the kind of translational science competencies we want to advance. Next slide. And I will now hand over the reins to Rachel, who will talk about continuing medical education information and how to claim credit.
Thank you very much. Hi, everybody. To claim CME, text the code to the screen number on the screen. The University of Chicago offers up to 1.5 AMA PRA credit. Physicians should claim credits based on participation. Other healthcare professionals will receive a certificate of participation. For AMA PRA details, check with your licensing board. The CME flyer and credit instructions we emailed after the seminar today. During the webinar, you will be muted, but feel free to ask questions or share comments using the chat function at any time. Remember to consider your audience when posting, and if you have something to contribute to the discussion, make sure to address it to both the panelists and attendees so that everyone can participate. Thank you very much.
Thank you, Rachel. So just a broad overview of the session today. Following our introductions, we'll introduce our speaker, Dr. Saulsberry will give her presentation. And following that, during that, we encourage people to put questions into the comment section, which Rachel will then uh, provide to the speaker at the end, a Q&A session at about 11:45. And then we'll have is our Incubator Hub expert panel discussion for the next 35 minutes or so, and some closing remarks. Next slide. So without any further ado, I'd like to introduce Dr. Loren Saulsberry, who is a rising star, and actually is a shining star at the University of Chicago, and she is an assistant professor of public health sciences and assistant professor of medicine in the biological sciences division and public health sciences at the University of Chicago. And she is a collaborator with everyone on this call, and is someone that I think is doing really extraordinary cross-cutting work. So, Dr. Saulsberry, thank you for joining us, and welcome to the lecture.
Just get my slides up here for a second. Okay. This will work. It's able to. How is that coming through for everyone?
Looks like, yeah. Are you in slideshow or are you?
I am in slideshow. Is that not how it's presenting for you guys?
Oh yeah, it is.
It is? Okay. All right. If anything starts to look a little wonky, please, someone interrupt me and let me know. But thank you for that introduction. And it's such an honor and pleasure to be here with you guys this morning to talk about a topic that's very important to me and my work, and hopefully give those who haven't, been in the field or who are learning about it for the first time some interesting new directions. So as was mentioned, kind of a topic of my talk today is advancing genomics to improve health equity. Currently at the University of Chicago, and assistant professor in the Department of Public Health Sciences and the Department of Medicine. And just to kind of give you a little bit of my background, I was trained as a health policy and health services researcher. And so I come to this work from that aspect and that lens. I have no disclosures to report. And just to kind of give you a landscape of what we're gonna cover today and how we're gonna think about it, our agenda. So, first I like to take some time in this to just give some definitions, common language. There will be many who are already familiar with the terminology, but some of those who are coming to the topic for the first time. So just to make sure we're speaking apples to apples. And then, as has been mentioned, I had the unique opportunity of participating in a National Human Genome Research Institute at the NIH workshop that was particularly focused on health equity and genomics, and brought together a number of experts in the field from various disciplines to really attack this issue and recommend some future actions that we could look to and outline a framework for thinking about progressing this work in the future. I'm also going to spend a little time setting up, which I know our esteemed panel will be able to expand upon in terms of future directions given kind of current context, climate, and where there are some additional opportunities to advance this work. I think the learning objectives have been mentioned, but really want to just talk about the landscapes of the gaps and opportunities here that are at the intersection of these two areas, human genomics or genomic medicine and health equity research. Think about some of these future considerations, hopefully to give some idea of where your unique work might be situated there. And from where I kind of sit this, I think a framework for how to conduct research and think about implementation of genomics into clinical care in ways that are equitable is important and highly translational, especially at the current time. So health equity, when we start mentioning health equity, what are we really talking about? And so, one definition for this term, although there are many, but one that I kind of think about and anchor a lot of my work around is one provided by the Centers for Medicare and Medicaid Services, which is focusing on the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to obtain their optimal health, regardless of race, ethnicity, disability, sexual orientation, sex identity, socioeconomic status, geography, preferred language, or other factors that affect access to care and health outcomes. I think part of this is kind of a focus, and one of the aspects of the report that was quoted here, it's particular to the context of genomics. When we talk about health equity, that means an opportunity for all groups and populations, social contexts and environments to consider all aspects of human genomics research, from the development of genomic technologies to the design of genomic studies, but also the provisional capacity and access to genomic data, particularly as it relates to the implementation of medical care. And human genomics. So what are we talking about when we say that? Well, it's the study of an individual's genes, the genome. Some of you might be familiar with the very famous Human Genome Research Project, which mapped the human genome, which was completed in 2003, which for some probably does not seem like that long ago, for others longer than some might think. But since that time, there've been just a huge outgrowth of different types of technological advancements involving genes, genetics, genomics. I think that this has been part of something that's been integrated really in this huge tsunami of a wave towards better personalized, patient-centered care. It's all based on DNA testing. So this just gives you a little schematic of some of the basic science there that could be involved. And finally, genomic medicine. So, we've talked about genes and genomics, human genomics in particular, and now genomic medicine. And so genomic medicine really refers, particularly within the kind of medical sphere, that's going to incorporate this genetic information that's being developed, in laboratories, that's contributing to drug development and other aspects of care, and really taking in that genomic information about an individual as a part of their clinical care for either diagnostic, treatment planning, or in kind of more of my realm of the world, measuring kind of health outcomes and policy implications for broader populations. So the NIH GRI workshop was entitled Future Directions of Genomics and Health Equity. Here's kind of a link at the top there that'll kind of give you an overview of the workshop. But the main kind of overall arching goal of this workshop was to think about and develop recommendations that were going to identify these gaps and opportunities that were going to be at the intersection of these two fields. And I think, starting off there was a recognition that this is work that's going to require multiple stakeholder engagement, that it was also going to require multiple different types of disciplines that were going to have to come to this if we were really going to bridge that translational cycle from lab to the clinic and then clinic to populations. And then even beyond that, to really kind of impact policy in a meaningful way, whether that could be reimbursement across different types of insurance types for genomics, or the incorporation of genomics into clinical care, and what would be some of the healthcare policies that could undergird and support that work. And some of the specific objectives of the meeting would really kind of leverage what was being learned in this rich and unique community that we had that had been doing a number of different research studies in the area, to identify those kind of opportunities in human genomics that are going to be important for advancing health equity, but also to think about specifically the ones that either hadn't quite come to fruition, or needed different funding opportunities, or perhaps different partnerships across that large stakeholder landscapes to further engage on. So to really kind of think about the ideas that were, maybe more high risk, high reward, that could have important improvements to the field. An objective was to identify research and partnerships that were going to be needed to understand and address factors to influence health equity in genomics. Spending some time problem solving. What were some of the challenges that various fields were engaging in this work, or challenges that different, broader populations were facing, genomic disparities that we were encountering in terms of both studies that were requiring representation of different populations of ancestral background, and how that was getting incorporated over time across this translational pipeline. And finally, to kind of design or start thinking about brainstorming of how we would incorporate measurements of success in terms of attaining health equity. How do we benchmark where we've come from, what we're currently doing, and where we might go in this area? Just to give you a little sense of the structure of the workshop itself, it was 2 days, attended by over 300 individuals from academic and non-academic backgrounds, and it represented kind of broad areas of expertise and perspectives. There were kind of set presentations that were given by speakers who had long, extensive research in the field and from their various perspectives. And then after each of those presentations, a panel of experts, responded to that research and gave kind of some thoughts, contextualization, and opened and answered some of the questions that were presented by some of the workshop attendees. Really actually enjoyable, and where I think some of the richness of the workshop came out was really in these breakout groups that followed those panel presentations, where all participants were kind of able to come talk about developing recommendations, maybe mention challenges from their own respective work that need to be incorporated. And those were all kind of recorded and considered within the broader group when developing the recommendations. As mentioned, this ultimately gets summarized and put into a perspective piece in Nature Genetics, and highlighted the recommendations that came out of the workshop. But it also took a step to, based upon some of the topics and the domains that were discussed in the workshop, to really scan the literature to give a kind of current view of where are we, in terms of published material and research in this field, and where are some of the areas for opportunity to continue to expand on the knowledge and publicly available knowledge at that about health equity in genomics. One of the first, I think, goals of both this perspective piece, but also a goal on the workshop was really, in educating others, but also just discussing what many knew to be true, but documenting these existing inequities that occurred in genomic information. Although many of us work in the field, we see that their genomic information and the incorporation of genomic technology holds a great potential for various applications within human health, that, frankly, not all individuals or groups or populations are being able to access those at the same rate, or may have the same utility from some of those technologies. And there, is even a question of, are some populations benefiting to the same extent, that equity piece, that others are, to really truly capitalize on all of the potential of these genomic advances to date. And the American Society of Human Genetics also published a report based on this, that I just wanted to highlight because it has kind of some extensive delving into what some of the different issues are, and where we really need to start closing some gaps related to equity. But you might be asking yourself, okay, there's existing inequities, health disparities within the healthcare system. I've seen or heard quite a bit about that. Why, particularly in genomics, do some of these inequities exist? And this is by no means an exhaustive list. I just kind of highlighted a few of the ones that were frequently echoed within the workshop. And one of those was there's a lack of representation of diverse populations in data sets. So in many of the genomic data sets that we have. It focuses primarily on data that's been collected from populations of European ancestry, which leaves a lot of various types of ancestral backgrounds left underrepresented and unrepresented there in those data sets, which can have meaningful implications based on genetics and various types of admixture of groups and the kind of new innovations and discoveries that can be made based upon important genetic findings there and applied to care. There's also gaps in kind of the research outcomes that apply to all types of populations that lead to, certain differences in the implementation of genomics into clinical care. So, if you think of that translational pipeline, first you have underrepresentation of specific groups that are in basic science. So the development of specific types of tests or the specific genes that are included on specific panels or tested for may be more prevalent in certain populations versus others. That then gets translated to clinical care, but those populations who were underrepresented then may face additional disparities in terms of implementation. And then finally, there's differences in views and perspectives across different populations that are really not always incorporated into clinical care. Now, this is something that we have a lot of data across the healthcare system, not just in relation to genomics, but I think there are some unique situations and circumstances, particularly related to genetic backgrounds, as this is really kind of about one's individual personal makeup and can have meaningful implications for families and specific populations. So, kind of culturally tailored approaches and ones that take into patient perspectives are incredibly important. So based upon, I mentioned kind of there was a literature review that was done and based upon some of the domains and topics that were discussed. This is just kind of a schematic of a summary of that. So, in the literature review, looking at, a various type of Boolean searches across, PubMed and other types of validated literature documents, they, found about 800 initial publications that could have something to do with anything related to genomics or health equity. However, upon review and multiple iterations that went into the systematic literature review, by the end of the study, they found that there were only about 72 that uniquely dealt with genomics and this capacity to advance health equity, right? So it didn't just talk about various health disparities. It didn't just talk about the concept of health equity or mention. It really involved within the study design, within engaging within the literature itself, how, some type of intervention or some type of work or new discovery that was really going to move the needle on advancing health equity. And so these kind of various both domains that came out in the literature review, but also came out in the workshop, really focused around equitable participation, diversity of the genomics workforce, partnerships, measuring health equity, and policy development. So, examples of this, equitable participation that really gets back to the underrepresentation that I spoke to in different types of genomic studies, again, kind of across the translational spectrum there, not just, laboratory studies and basic science, but also implementation and broader population health focus. Diversity of the genomics workforce, really thinking about representation here as well, not just in terms of those that have different types of positions, either academic or non-academic, but really thinking about the topics, right? So the various types of areas in which research is funded, research is promoted, those types of areas. Partnerships, I mentioned a broad kind of array of different stakeholders from patients to provider care teams to researchers to community-based organizations and everyone in between, insurers, payers, everyone who's kind of involved and touches one way or another the healthcare system, and thinking about what are the various ways that we can enrich those partnerships to advance health equity. policy development. So a good focus of the workshop here in policy focused around thinking about privacy issues for individuals, but also in terms of institutions who are want to protect that information, but also to be able to kind of have the ability to conduct the research and the studies. Policy development can also involve broader healthcare policy, right? And it's here in the top left corner, but it was actually the area where it led to a kind of noticeable gaps that from different areas we saw in terms of measuring health equity, and particularly scholars that have and social scientists that have been in the field and specifically focus on that across an array of different areas, not just genomics. That this has been a consistent challenge. What are the right metrics that can be applied either to general populations, but also in specific contexts that really are measuring health equity? And how do you ensure that those metrics are picking up the important information to make them most useful into care decisions and have the greatest impact? So from the workshop, we came to a number of different recommendations that were focused on, and we summarized these recommendations, both that were discussed in the workshop, but also ones that came up in the literature review. So one, again, thinking about diversifying the genomics workforce was actually kind of found in both. Addressing the lack of population diversity in genomics research and current existing biobanks was another that was found kind of from both sources. But accessing how this lack of diversity in populations and communities that make up genomics research cohorts might impact health disparities. We talked quite a bit about that in the workshop, and that'll be the source of some of the work that I've done in this area. But it didn't really come up as much in the literature review. There's kind of a few papers that ultimately didn't make it into the final analyzed sample that may discuss the concept of kind of health disparities research in genomics, but certainly came out and illuminated to us that papers that are specifically focusing within this topic area around health disparities definitely deserves kind of a greater attention and focus. So addressing outcomes that were important to all communities. I think what we saw in the workshop was there were a lot of different kind of groups that researchers had focused on either throughout their careers or at different times, and were highly kind of knowledgeable about those areas and what was unique to that group. But kind of the 360 view of what that would look like in terms of genomics from either kind of a utilitarian perspective or beyond that. There was much more theoretical literature that had been published around that, and less so on the application side that saw that kind of within implementation, this is something to potentially focus on a little bit more in that area. Addressing inappropriate use of population descriptors in genomics research. So this was a incredibly important and debated topic that came up. One in which has a long history within academic research of being focused on, and generally because how you describe a population can have meaningful implications, and language is really important and does matter quite a bit, particularly if our focus is on equity and expanding representation in genomic studies. So we found that actually both in discussion and also in the literature review. Increasing the utilization of genomic markers rather than just population descriptors in clinical algorithms. I think it's accepted now that race is a social construct, and there's been, and I've kind of looked at this as well. If you take kind of a scan of different studies, whether it's race or ethnicity or ancestry, really depending upon the study design, there are population descriptors that have greater use and utility than others, both to the study, but even kind of in a broader context of supporting kind of equity considerations in terms of the implications of the findings. So, we talked quite a bit in terms of the workshop is the importance of that and the matching the population either targeted for the study or that is actually, included in the study population. But, particularly, I think our community partners were helpful here and, again, incorporating the patient voice and the individuals who are participating and stand to benefit from this research in considering the population descriptors that are meaningful to them in the context of their ancestral background as well. So again, thinking about including contextual variables of diverse settings, we found that, again, I focused on thinking about different partnerships across different sectors. We talked quite a bit about kind of public sector collaboration as well as private sector collaboration. Again, getting communities more involved. And, particularly within genomics, there are a number of scholars who emphasize, building trust. There's some communities that we have a lot more work to go to do in that area of building trust, and others in which it's going to be important to maintain what trust has been built over time that researchers and others have really spent quite extensive efforts on. And all of that has to be kind of considered in future directions. Respecting views and autonomy of participants and communities. Again, I think highlighting the importance of incorporating kind of patient perspectives, culturally tailored values, and considering what the implications may be for different groups of genomic studies. Thinking and developing about metrics for health equity and how to apply those to genomic studies, and specifically developing policies to kind of address those health disparities. I think there are definitely a number of different domains, whether you're thinking about kind of structural upstream policies to affect this versus ones that are, in the healthcare system. There's really no consensus, I think, that we came to in the discussion around this, which was, mostly that both are ideal, and however, in terms of limited resources and context for both research studies, where do you kind of address those policy interventions? And thus far, although there is some literature in that area, there isn't a specific context or direction that's specifically promoted. Okay. Oops. Okay. So those were the recommendations of the workshop that we discussed. And I just wanted to take a minute. I know that probably many of you thought that maybe you were going to get away from one of these talks from having to look at some data, but I just wanted to give you some examples in terms of contextualize of how to think about, or one example of how I've been doing some of this work and looking at health disparities and thinking about advancing health equity and genomics. And so part of this has been in my own KOA Career Development Ward, which is focused primarily on pharmacogenomics, which studies how genes can affect a particular person's response to medications. And again, as kind of I've mentioned in the overall workshop and we've discussed, one of the things that drew me to this work, coming from kind of a policy and health services research background, was I really found a number of different health shortages kind of in the evaluations of how pharmacogenomics is really impacting health disparities, right? Was it increasing them? Was it working to reduce disparities in certain areas or particularly related to any types of chronic conditions? And so I really wanted to spend a little bit more time adding to that literature. So one of the ways that I looked at this, particularly as someone interested in chronic disease here in the United States, was to look across some of the highest drivers of morbidity and mortality in the United States, and to do that within kind of a nationally representative database. So I used the Medical Expenditure Panel Survey, which incorporates patients across all states, and also focuses on clinical validation of some of the patient-reported measures that are provided in that survey, so that when you're looking at prescription drugs or utilization or even costs, there's kind of an extra step of validation beyond just patient report. And looking at this across different kind of chronic conditions and different types of underrepresented groups, we found that Black respondents were less likely to report kind of a prescription with with medication for kind of evidence-based pharmacogenomic drug gene associations. Much less frequently kind of than their white counterparts. So all of these different bars that you see are compared to a reference group being the non-Hispanic white population. And so, noticeably for us, we saw kind of different patterns in terms of probability of exposure to these types of drugs, but also ones that differ across, types of chronic conditions, which, is meaningful when we consider the prevalence of these types of chronic conditions across populations. So it's one way we've kind of looked at this. Another was to look in the context of within clinical care to think about how pharmacogenomics is actually being implemented. In another study, we focused on a cohort of only African Americans that the University of Chicago participated in a large study on. And we really focused on the inpatient setting there within that study to derive, when patients are pharmacogenomically tested, when they do receive this genetic testing, what are the opportunities and what's the applicability kind of within the inpatient setting to potentially intervene on medications that are going to be, cautionary and may cause adverse events for these patients or other kind of downstreams negative health outcomes. And we found, about 29% of these newly prescribed medications within the hospitalization context really could potentially increase toxicity or risk for suboptimal response were being prescribed to African American patients. And what was interesting in this study that we didn't necessarily expect because we were looking at the inpatient setting where frequent medications are being prescribed. And so we thought that would be a potentially good time to intervene was you found at the time of discharge, we ended up evaluating what patients were leaving with, based on kind of my experience in health disparities. A lot of the issues for underrepresented populations is they don't typically have a usual source of care. And so there isn't, kind of a set program always for prescribed medication management. And so, pharmacogenomics, the hypothesis was, might be an opportunity at the time of discharge for that to occur and to prevent some downstream negative effects for those patients. And we found that about 1 in every 5 medications that were being prescribed at the time of discharge, were associated with some of these cautionary pharmacogenomic findings, and that having that information available to prescribing providers could, in fact, recalibrate some of those prescriptions and improve drug outcomes for some of these patients. I've also taken a look at this in terms of thinking about communication, right? So we talked about patient-centered and incorporating patient perspectives. But what is that involved in terms of the patient-provider interaction around these different types of genetic test results? Not necessarily, the full comprehensive evaluations or discussions that can happen with the genetic counselors. Those are fantastic, and some health systems do have that incredible built-in infrastructure. But with, at the point of care directly kind of with a provider in terms of that. And so, we looked at this across different kind of educational backgrounds and race, ethnicity, and, particularly found that patients were less likely to report initiating discussions that were about kind of their personal makeup or genetics, and that they did so kind of far less frequently than their kind of non-Hispanic white counterparts. Indeed, of about kind of 43 patients, we only saw 2 that indicated that they were specifically felt empowered to ask their physicians about this type of information. And that really, changed by kind of educational background, those with, less high school or less education, or some, weren't reporting being able to do that at all. So, seeing that there's kind of real opportunities within the direct kind of risk communication around genetics between a prescribing provider and patients of different backgrounds and amplifying that engagement. And finally, kind of moving to thinking about other aspects and holistically considering, the experiences that patients have that affect both their medication management, their treatment, but also kind of their ability, to manage, complexity of various types of health conditions and advice related to that. We wanted to really start thinking about some of what are the other social risk factors and social determinants that, may impact kind of downstream upstream hospital readmissions based on patients who were receiving kind of prescribed medications that had kind of a gene-drug interaction. So, we looked at, 90-day hospital readmissions and the institution of prescription drugs for gene-drug interactions, and particularly wanted to adjust these by a lot of the social determinants of health that we both conceptually and from the literature and in various studies had seen kind of impact in various different ways. And once you kind of start accounting for a lot of these social determinants of health, you really see kind of this subsequent risk reduction after adjusting for them in terms of implementing pharmacogenomics into a hospital setting that reduced some of the risk of that adverse patient outcome. Here, looking at 90-day hospital readmissions and, to expand this to other types of healthcare utilization. So all that to say, I summarized that from this workshop, one of the biggest things that came out that we have a dearth of right now is, ways to measure both disparities, but also to think about metrics that are meaningful in terms of the social determinant, social vulnerability, and what that would look like in evaluations within genomics. And so, we've taken kind of one step to looking at that and evaluation of 90-day hospital readmissions. But this really kind of got myself and a number of collaborators interested in this concept of social vulnerability, which applies across the socioeconomic spectrum and to all patients. So it's truly a concept focused and thought to be based in the idea of health equity. And the social vulnerability is essentially thinking about all the ways that you could be susceptible and environmentally at risk based on social factors in terms of your ability to withstand external stresses on human health, right? So you can think about this as a diagnosis of cancer, a diagnosis of cardiovascular disease. You could think about this as economic insecurity, housing insecurity, food insecurity. There's lots of different things and factors that relate that are health related and could affect your ability to kind of maintain a current level of health status or improve upon your health status given those factors. And so I kind of led a team and got together to think about this in a meaningful way and look at other metrics that were currently out there to really start picking up and measuring social determinants of health and thinking about social vulnerability to be applied in various different types of contexts, and specifically to some of the work that I was doing in pharmacogenomics. And we found that, as many researchers do, a lot of the existing tools, they just had limitations and different things that we wanted to improve upon. And so we created our own. So I helped develop what we entitled as the social vulnerability metric. And so it's a composite measure that represents over kind of 200 social determinants of health measured variables at the national scale. And we wanted to benchmark it to something that was used consistently in the field to make sure that we were, we had some precision and we were really kind of making a contribution that was going to be an enhancement and not a deterrent. And so we compared it to the Center for Disease Control's Social Vulnerability Index, which incorporates race ethnicity. And we made a specific choice not to include race ethnicity into the social vulnerability metric, as there are various aspects of social vulnerability and social determinants that are certainly highly correlated with that. And there are others that are not. And we wanted to be able to, again, apply contextually at different geographic levels this area-based measure that would incorporate those various types of background considerations, but often could enhance and find and measure social risk in ways that was not directly linked or correlated to that. We also made this tool publicly available, so it can be downloaded in terms of scores and percentiles and used across the healthcare system. And specifically focused on implementation, one of the things that was important for me to do is to link it to something that's consistently recorded within the healthcare system. So other studies have focused on census tract level or county levels of analyses or neighborhood. But within a electronic health record, often the information that's collected is zip code. Now, with zip code, you can kind of in various statistical techniques, increase the level of that up into larger kind of geographic levels. But we wanted something that we could ultimately apply and perhaps provide to providers and others that could then potentially be actionable within a clinical context. So just some of the validation and the data on this, in employing the social vulnerability metric, we first wanted to start looking at all-cause age mortality. We did that, and across the country, again to the left here, lower scores would represent lower social vulnerability, whereas higher scores would represent higher social vulnerability. You see our SVM score here in the blue, and the red is the CDC's social vulnerability index. And we found kind of a greater correlation and improved precision in being able to predict all-cause mortality with the social vulnerability metric. We wanted to try this at a smaller level, again, looking at zip code and calibrating it there. So we also looked at COVID-19 mortality rate here within the city of Chicago, and also, found a high correlation and predictability as to COVID mortality based on social vulnerability. So, altogether, what are some of the future considerations then based on the workshop, some of the research that I've been engaged in to think about here within health equity and the genomics context? And one, related to metrics and why, I didn't necessarily start out as a person or a researcher even that was going to build out new metrics. I think, that was a wonderful addition and a new direction that I've taken in my career, but it really came out of wanting to find better ways to improve measurement in a particular area. And so, how do we continue to examine health equity in the context of genomics and genomic medicine? And there is still abundant opportunity for new metrics that are needed to really kind of measure success, both in increasing health equity, but also metrics that are needed to bring in elements of the patient experience that are not currently there to guide and direct care. I think what are going to be the receptivity going forward to health equity research, studies, and the ways to do this? This work is deeply important to many patients, and it's also deeply important to a lot of practitioners and researchers, those of us who work in the field. A lot of it is also guided in terms of kind of NIH priorities. What we've seen, and this was discussed in the workshop as well, is funding opportunities. One of the direct links that came out of the workshop, although many of those mechanisms have expired now, were specific and targeted funding mechanisms for research that would advance health equity in genomics. So, all of those things kind of within this broader ecosystem really are needed to work in tandem to push the needle forward. In terms of health system changes, I think there are some questions there in terms of whether it's insurance and reimbursement, or in terms of the particular mechanisms by which implementation is occurring, both across the country, but in different care settings for different conditions. And technological innovation is always a very large consideration. What new technologies come onto the field? How do they get diffused with all the healthcare system? In many instances, there's evidence to suggest that new technologies, exacerbate disparities. Sometimes that levels out. Other times they become persistent. So how do we interrupt that cycle? I think is also a common question. So, with that, I'll, primarily conclude, genomics has been a huge advancement within the field, both from a scientific perspective, but also in terms of the new capabilities that are there to, promote health and treat human disease. It's a balancing act, certainly, and sometimes that balance gets out of whack. And, we hope to kind of find ways to rebalance that care, but most importantly, to do it in a way that impacts, all populations to give them equal benefit from these new technologies. And with that, I will kind of acknowledge everyone that participated in any way at NHGR in the workshop, my advisory committee for my Career Development Award, our UChicago lab, all co-authors and collaborators that were part of this work, and my own funding and support for these various studies. Thank you.
Thank you so much, Dr. Saulsberry. At this time, we will take some of the questions that have come up in the chat. Let's see, Dr. David has said, can you comment on the observation from the 90-day readmission analysis that African American patients with drug-gene interaction were more likely to be readmitted compared to white non-Hispanic counterparts?
Yes, absolutely. So I think there's a couple of things that can be going on there. For one, there's a baseline level of difference already. I think kind of across populations, which could be related to kind of health status, could be related to exposure to prescription medications. We adjusted for that actually in the analysis to really kind of isolate what would be specifically related to those 90-day admissions. There's also, a difference in kind of prevalence for pharmacogenomics across, particular variants that indicate higher risk versus lower risk across those different populations. And, the resulting kind of phenotypes that can cause kind of some of the health issues that would result in someone having to be hospitalized that differs across populations. And so, we, believe that a lot of that kind of drove those two different findings. But again, even in that context, what we saw was once you start taking into account these other kind of social risk factors that are engaged with that, all of those kind of risk levels and probabilities were lower for some of those adverse hospitalizations.
Thank you. At this time, we don't have any more questions in the chat. So if anybody has any other questions for Dr. Saulsberry.
Thank you, Dr. Saulsberry, for your excellent talk, and thank you for the work that you are about to embark on that will change the world for the better. So thank you. Um, so I am a physician at Stanford. I started the first pharmacogenomics clinic at Stanford in 2018. And one thing that I have been frustrated by as a clinician is that I am seeing patients of diverse backgrounds and I get pharmacogenetic reports that tells me about variants, and I realize that most of the pharmacogenetic and genetic studies are on European Caucasian populations, and I may be, in some instances, providing false reassurance to patients simply because we don't know. And warfarin is an excellent example of this. We took warfarin variants from European populations, applied them to Black African American populations, and the prevailing wisdom from that is that pharmacogenomics is not useful for warfarin simply because we, you know, took apple variants and applied them to oranges, and that doesn't work. So I wonder if you can think, and incidentally, Dr. David and I have written an article on this about false reassurance, taking variants from specific populations and applying them to other populations and falsely reassuring patients. And Dr. David, if you happen to have the link to that article and can drop it in the chat, that would be great, I think, for the attendees. So Dr. Saulsberry, I wonder if you can think beyond the KO8, which is going to be amazing, but sort of 20 years down the road when I'm retired, how is that going to change for who I pass the baton on to for seeing patients?
Sure. Yeah, no, those are excellent points and a great question. And I hope to spend my career answering just that question. I think as of right now, some of the ways that I conceptualize it and frame it is, for me, it emphasizes the importance of team science. It emphasizes the importance of having individuals, in the lab, that are, using what rich, ancestrally diverse data we can have and to really focusing on that. And the discovery of kind of new variants and technologies there. One of the issues is what you're talking about is, it really depends on what kind of tests are developed and are employed in different pharmacogenomic contexts, right? We know that there are specific variants that have higher, prevalences in, say, Asian populations, like maybe, HLA, or you mentioned the warfarin example, even DPYD for cancer. There are certain variants that have different higher prevalence within populations of specific ancestry than others. And so, this kind of false reassurance is, if you're not necessarily testing for the right variants that mean the most to a population, then you are in some way gonna, miss out on some of that valuable pharmacogenomic information. The exact solution, like I said, I think because all that takes time, right? The development of a discovery of new variants, the implementation, all of that takes time. I think, certain things that we can do today, and part of, some of the studies that I've started focusing on are really around kind of risk communication, right? Being very clear kind of in patient and provider interactions, or, who, whether it's delivering that care, that information from a pharmacist or from a genetic counselor, as to what the limitations are of what we currently have, and for what populations those are going to, truly, maybe have some more precision than others. And so, far we've kind of done some piloting of different kind of surveys and focus groups. Patients are actually more receptive to information about, uncertainty when it's kind of, given directly as opposed to in some ways by some institution in limiting that. And the other thing I'll just say that we found is that there's actually quite a bit of trust in the individual provider. So I really do think that there is a role here in those kind of direct patient provider dyad interactions to kind of really fully kind of sketch this out and scope it. But there are some limitations currently to what we can do, but I think it's going to be kind of team science efforts across population scientists, clinician scientists, as well as basic scientists, to kind of close out this translational spectrum and to start kind of interrupting that.
Thank you, Dr. Saulsberry.
Great question. Thank you. All right. Do we have more questions from the audience?
We do. We have one last question.
Okay.
And this is from Sally Jensen, who says, "Thank you for this presentation and all your important work. I'm wondering if you might speak to some of the patient-centered gaps and how, as researchers, we could approach these gaps in terms of assessing outcomes in a culturally appropriate way in research."
Absolutely. So some of the, ways and which we've been focusing on this is really thinking about community engagement and getting, different populations from patients. I think there's lots of different types of, intersectionalities that could be involved there of patients that have interest in this group. But I think, having this bidirectional research to also community and patient engagement in terms of, using some of the kind of patient-centered, concerns, challenges, what's, been difficult for them, or kind of their experience either with genomics or, in general, kind of with social risks or health-related factors, and getting that incorporated to researchers for involvement in study design, for, tailoring and to implementation plans, or, where clinically appropriate to treatment plans, and how that is involved. But then I also think it's, that greater enjoyment, that bidirectional flow from the providers, to really, start listening and to bring in more of kind of that, patient-reported experience into, care. But, I think it's I don't want to say it's just education, because it's not just education, but it's really more of what I'd say problem solving on kind of both ends to attack some of where those gaps currently are, and bringing resources from each area to contribute to those.
Thank you. That's a great question. All right. I think we're ready to segue to the panel. Okay. Well, thank you, Dr. Saulsberry, for a very enlightening talk, very insightful, and I like the way that you integrated your pharmacogenomics research to stress some of these points in very tangible ways. So I'd like to introduce our panel. We're really, it's a real treat to have this panel today. We have Dr. Manoli Pereira, who is PharmD, PhD, and she's an associate professor in pharmacology at the Feinberg School of Medicine at Northwestern University. We also have Dr. Latha Palaniappan, who is a professor of medicine and cardiovascular medicine by courtesy epidemiology and population health at Stanford Medical School, School of Medicine. And then we also have Dr. Mark Dunnenberger, who is the director of pharmacogenomics at Endeavor Health, PharmD. He is assistant vice president, personalized medicine. And he has been the Prometheus who built our whole pharmacogenomics program here. So we're honored to have this panel. And we're going to go on to our first discussion question. So we can go on. So this first question here is, given what we saw presented, how can we implement results from this workshop to advance health equity in our health systems? And pharmacogenomics is one example, for example, of patients with adverse drug reactions who might be able to have full care continuum wraparound services to help keep them out of the hospital. But in general, there's a lot of issues that were raised today. So I thought go to the panel, get some of your thoughts about this. Dr. Pereira, we'll start with you since you're at Northwestern. What's some of the thinking about how your work is being translated into the health system?
So as Dr. Saulsberry had mentioned, like the path from discovery to implementation is really quite long and in some ways arduous. And I think one of the barriers or things that we should be thinking about, especially for minoritized populations, ones that don't have as much representation in many of the sort of guidelines that we write around, whether that's pharmacogenomics or even genomic medicine, around predictive, disease prediction, maybe to think more creatively on how we push that through to implementation. I think we have a lot of standards around randomized clinical trials or pragmatic trials as the ways in which to as the best sources of information on whether pharmacogenomics should be implemented or how it should be implemented. And going through those processes, especially as we discover new variants that may affect specific populations, may be overly burdensome and honestly may take too long to bring real health equity. So I think one of the changes we need to think about are more creative ways in which we can start thinking about implementing without waiting for sort of the preponderance of evidence to be a clinical trial. And I see that in my current work, but also in implementation work. I think the other thing, there was I think in the chat about polygenic risk score, which is, gaining popularity certainly for genomic medicine, but thinking about combinatorial sorts of analyses as we move forward. This would be most useful because that means that we would have more genetic variants to think about and would not be picking and choosing which variants we're testing, especially when those variants are based on European cohorts.
Thank you very much. And Dr. Palaniappan, some thoughts about what you've done in the 10 plus years of implementing at Stanford to try to expand the reach and the relevance to minority patients of pharmacogenomics. Oh, you're on mute.
Thanks for that question, Dr. David. And a lot of the work I've done in this area has been in collaboration with you. So thank you for your leadership in this area as well. And I think that Dr. Saulsberry and Dr. Pereira have well pointed out the current deficiencies in our state of the science. And what I am really excited about going forward is moving more to genetic sequencing as opposed to genotyping. And as a clinician, sort of the star allele Genotyping drives me a little crazy, especially when we do that for pharmacogenomics, and then for genetics, we're using the RSIDs. And I really do think that we need to bring this Tower of Babel together for our primary care clinicians, especially because, there's just too much to ingest, and it can't be, if then that, it has to be a little more streamlined, I think, to incorporate it into our primary care practices. As you have well documented in your work, and also Dr. Dunnenberger, thank you for the work that you have done in this area. Definitely have learned from both of you and your work in Chicago. And in addition, I think because costs are decreasing so much, and I was just at American Heart Association in New Orleans, and as many people on the call may know, I was an author on the new Prevent guidelines, where we created new risk scores for cardiovascular disease, now incorporating kidney markers. And that was done with a database of 6 million people. And just as a reminder to us, Framingham, where we had the first cardiovascular risk scores, had only 150 events out of 6,000 people. And then the improvement upon that was the pooled cohort equations, which had about 42,000 people. And now we have risk scores that we have derived on 3 million people and validated on 3 million people, largely due to the electronic health records that we have, our ability to aggregate and analyze big data. And we really need to apply those principles to how we move forward genetic and pharmacogenetic guidance for our clinicians. So I'll stop there.
Thanks. You do raise a really important point outside of pharmacogenomics, which is with transethnic polygenic risk scores, how we use them and how valuable they are versus population-specific ones. So maybe we can come back to that, as a translational science challenge a little bit. But thank you for that response. So, Dr. Dunnenberger, thoughts about this issue in our health system and addressing, I think, reference frames for diverse patients and how we go about implementing some of this type of work here.
Yeah, so appreciate the panel's comments so far, highlighting that there is a process out there for gaining more evidence about what genetic variation means. You definitely have to do that in a diverse patient population if you're really going to understand what's going on. I spent a lot of my time trying to implement genomic data based on evidence into practice and drive that to value. And I think we have a couple of problems right now with pharmacogenomics. Let's just call them opportunities, maybe is a better way to think about it. Defining what is the value of pharmacogenomics, truly, like using this data is going to do what for my patients, and proving that whatever that what is actually true. So knowing that value, and then as you know that value, you can start to develop the tools to get it done, right? There are a number of ways of doing pharmacogenomics today with clinical decision support, most of them focused around the provider. Nobody knows what's the best way, or even the couple of best ways of doing that. And it's kind of hard to define what the best way is if we can't define the value of presenting that data. So we've got to tackle that. But even once you're able to tackle that, that's just on the provider side, and it doesn't deliver the data to the patient in the best way. And ultimately, because these data are true for a patient's whole life, empowering the patient with these data is going to be the most important thing, right? So we've got to start coming up with patient-focused clinical decision support tools. And the only way we're going to get to the best solution there is to try many solutions over diverse populations, kind of in a startup manner where, try a lot, fail, but learn with every failure. And doing that across a diverse population, it becomes incredibly important. And you see that in some of the work that we're doing here, where we have implemented genomics. We have a pretty large pharmacogenomic implementation on the clinical side. we look at how the health system is performing across kind of the care journey, and then start to understand how those populations look at each step, and then go do qualitative research with those populations, and then let them come up with some solutions, and then we implement it back into practice, and we just keep doing that over and over and over again. We don't do it as fast as we should, which is a little sad. I'd like to be doing it every day, but we don't have the resources to get that done. But the more people we get into the process, the more diverse populations we get into the process, the better solutions we'll have for everyone. And so I think that becomes really important. That'll wrap up my comments there. Do want to hit on one other thing real quick. The nomenclature issue, right? We spend a lot of time in pharmacogenomics building kind of walls of like, there's pharmacogenomics, and then there's the rest of germline genetics. Every day that wall breaks down as we learn how things that the rest of germline genetics call benign actually have some pharmacogenomic relevance, in that it may dictate therapy. A channelopathy gene may not cause long QTC on its own, but if you're given a certain drug, it will reduce like that kind of threshold. So benign on the germline side, incredibly important in the drug recommendation side. If we teach pharmacogenomics as star alleles, that wall gets really hard to be broken down on the clinical implementation side. But on the evidence side, it's crumbling, and we're going to have to deal with that. So fun problems for us to go after over the next 5 years.
Can I add one comment to Mark's comment? Because I think it's really, really good and important. Which is if we continue to live in the star allele world, I think there's like a natural inclination that if you don't carry star alleles, that you're what people call wild type, and there is no wild type in humans. So I don't really like that that phrasing, but that's kind of the sort of default. And I think there's a real problem there with thinking of wild type versus star allele carrier. And I think what Mark is talking about really hits to that as well, that we have to think about being more broadly inclusive of the variants we're thinking about.
Yeah, and I want to, sorry, Dr. David, just want to emphasize and add to what Dr. Dunenberger and Pereira mentioned. I was just seeing a patient who was a UGT1A1 homozygous, and that is definitive for Gilbert syndrome. And this patient's 83 years old and had elevated bilirubin, off and on their whole lives. And I think in addition to, I think we, as it has been said, we need to break down the barriers between pharmacogenomics and genetic testing, because there's a lot of overlap. And I'll also mention factor 2 and factor 5 Leiden, also very important overlap there.
Yeah, great. Thank you. I wanted to come back to a slide that you showed, Dr. Saulsberry, NPG paper from the account study, where you queried African Americans' communication experiences about pharmacogenomics. And also this is Dr. Pereira's study as well, the account study. There were how many African Americans with cardiovascular disease in that study? A lot, like over 1,000. And they were followed clinically, and this, I happen to know, has a high admission readmission rate population. So any insights from that study that might help us going forward with implementation based on what the patients were telling the investigators would be interesting. That's a big question. I'm sorry. Any summary points from that paper, Loren, or to talk about?
So in that paper specifically, we were kind of just focusing on the implementation side of that. As you know, Dr. David and Dr. Pereira can speak to this more. There were, different types of translational aspects that were involved in the account study. So, Dr. Pereira would have kind of an overarching view of all of those aspects, both from, the scientific portion as well as the translational and implementation side. The sliver that we looked at specifically in that paper was just kind of within implementation, across the various sites. So we had the University of Chicago, Northwestern, and the University of Illinois, Chicago. Kind of within that, when patients reported kind of what their experiences were. And now these are patients that had already gone through a consent process, that had already gone through genetic testing. So you would expect a kind of higher a certain level of comfort and literacy around kind of at least the study that they were engaged in, than just the general population that wasn't being a part of a pharmacogenomics implementation program. And I think there are various ways and different studies and papers and publications that have come out, evaluating account, really demonstrating to the high quality of care across those institutions within this pharmacogenomics implementation program. And even then, I think with increased attention from being a part of the study, with the added benefits that were observed, kind of receiving pharmacogenomic guided care, we still saw communication gaps that were across different populations, and even within those populations. Because one thing that health disparity studies typically do is they kind of do these comparisons that are just across either racial and ethnic populations, or just across socioeconomics or different things. They often don't get into the large diversity that is within each of those populations. And so I think for us, what was particularly unique about having this all African American cohort, that also had a range of different types of comorbidities in addition to the cardiovascular conditions, was to be able to see within that group that has been historically medically underserved and underrepresented, and especially within kind of pharmacogenomics implementation studies, where specific types of risk communication around their genetic background and their personal makeup could be assessed, and also so that we could start thinking about what those interventions might look like at the point of care when that information was available.
Mhm, mhm.
I'd just like to follow up and say that that answer from Loren was just superb. First of all, around the looking at the diversity within a population. This has been something I have actually been talking about for forever. And when I talk to people, just even in genomic medicine, when they say, oh, let's say a cancer cohort, and we're going to compare, European ancestry individuals with this cancer versus African ancestry people with this cancer. And I always say that's not an incorrect analysis. There's nothing wrong with asking that question, but it's going to give you a different answer than asking what is the difference within that population for people who, let's say, did better or did worse or something. That's going to give you a very different answer. And so thinking hard about the question you're asking, I think, is what one of the reasons account was run the way it was, which was all of our participants were African ancestry, and then asking within this population, what are the things that may increase implementation or increase uptake for pharmacogenomic recommendations, or what are things that are more predictive of adverse events within this population, not per se between populations. And I think this is a very, very important distinction that sometimes gets overshadowed as we start looking at very, very large data sets that use trans ancestry work. Again, that's not to say trans ancestry work is bad. It's great, and we should have trans ancestry work, but it will answer a different question that within population work.
Thank you. I just wanted to do one for the generalists or who don't know what the star allele is, the audience. There are some genes that are massive, million base pairs, and they have all kinds of different molecular variants. Some are deletions, some fold over on each other, translocations. Some are single nucleotide base pair changes. The way to keep them all straight and with a lot of complex genetics is to have the star system that basically, as a heuristic, comes up with star one, which is kind of normal wild type, and then star everything else. And with this system, it's easy for some of these alleles that are like star 39C in some populations where we're not capturing the diversity with it. So people may propose phenotypes. That is, are they a fast metabolizer, slow metabolizer, intermediate metabolizer, as a better way to bend things together. So that's where that comes from. But then moving on to this next question here, health equity in our community. So there's been a lot of community engagement work that has been done at our institutions, and this is true for certainly for Stanford and Northwestern, University of Chicago, Endeavor Health in our communities, talking to communities, doing workshops, doing mixed methods work. Learned a lot about some of the barriers to participation in precision medicine research and care. But it's really, where do we go next? Now that we have learned all this and we're seeing some patterns emerge in different parts of the country, although every community is different. What's next? So thoughts about how to implement results from these recommendations and our collective work going forward with our community partners and with citizen scientists and the networks that we have built. I think it's an exciting time, really, because I see there's some enthusiasm and a sense of why can't we have that? I'm hearing that from a lot of community members, and so what are some thoughts, Dr. Pereira, with your catchment area and how you're moving forward? Because you actually involved with a large network study right now, aren't you?
Right. And much of our work continues to be on the discovery side, but for the implementation side, I think actually Mark hit on something that was really, I think, really great, which was the idea of empowering patients to take ownership of their data and to build applications that use that data. And one of the real benefits around genomics and using genomics is that as we were talking about, if you sequence, that's it, right? If you have a sequence of a patient that's never changing, what changes is the interpretation of that sequence. And building applications in which we can reassess with new discovery. So my work is a lot on the discovery side of what should we be considering as we move forward in pharmacogenomics and genomic medicine. But implementing that is difficult when platforms are already made to genotype, star alleles as an example. But if you have sequence and then you can reinterpret that sequence with added data and with the idea that some data is more reliable than others, right? Like is more well established than others. I think this is a kind of the way forward to be sort of this iterative process where you may get a risk score that is at one point in the science, but may be changing as we get more information. And I think one hard part about that is having the patient population understand the evolution of science. I think there's a kind of a black and white, certainly now, ideas around science, and that's never how science has worked in perpetuity, right? We've never been a black and white sort of world. We are continually evolving, and this science certainly is evolving as well.
Thank you very much. Yeah, it's just Dr. Edinburgh and I were at an IH meeting a few weeks ago, and we saw work from the University of Florida group where they have passports that they give to patients, and they bring these. There's QR codes, and I know that you're all familiar with this idea for around pharmacogenomics, but it could very well also be that the QR code, there could be maybe a polygenic risk score for cardiovascular disease and your risk or something else. What are your thoughts about democratizing this, and like what kind of policy change do we need to see for this to actually be useful for patients? For example, do we need CMS treatment coverage for pharmacovigilance for patients to meet a certain threshold? Or do we, are there policies that would make this through CMS more affordable for everyone? Thoughts on policy change? These are
I
big
think
questions, so I know they're not easy to answer. But
I'll just say a few things,
yeah.
Dr. David, and I wonder, I know you're the moderator, but you're very humble and modest, and would love if you could share with the group the work that you did at Stanford through the Sphere program on health equity. And before you talk about that, I mean, I would love to just say that we need to provide psychological safety in terms of genetic testing in this country. And we do have GINA, the Genetic Information Non-Disclosure Act. But as you know, it does affect and can affect long-term disability insurance, life insurance, etc. And I don't think that we have the level of psychological safety in this country that we need in order to push forward sort of high throughput genetic testing, particularly in populations that have um, mistrust and for good reasons in this country. So I'll say that, and I'll let you turn it over to you, Dr. David, to talk about Sphere.
Oh, sure. Great. Thank you for bringing that up. So, yeah, I was really fortunate to be part of a program project that Bonnie Maldonado and Mark Cohen and um, um, uh, Goldman Rosas and many people did at Stanford. That was funded by NHMI, National Institute of Minority Health Disparities. But our implementation core did mixed methods work of 8 communities in the Bay Area, and they included Vietnamese, Chinese, Mandarin speaking, English speaking, Latinx, English speaking, Spanish speaking only, African Americans, and their primary care physicians. So this was extended to the East Bay. And we addressed issues around knowledge, attitudes, interest in precision medicine, barriers, and so forth. And so a lot of what we heard was that not everyone has the same level of concerns or enthusiasm for this, but there's not only historical, but there's very real present structural issues today that create barriers. And so we've determined that we need to approach every community as its own community, so that we're not going to see necessarily the same things everywhere. But what I was excited about this was that 10 years ago, when we all collectively wrote the grant, this idea of the nexus of health equity and genomic medicine being a new frontier in public health was really new and exciting. And I still think it is a frontier where we could have a lot of impact, because there's many things from a global health standpoint, like thalassemia and sickle cell trait and a whole range of things. Maybe, and CRISPR, gene editing and things that could really transform the health disparities landscape that we have. So I'll just give credit to all the smart people I got to work with there at Sphere. We published a paper, as did Dr. Manoli's group, and working with people at the University of Chicago. But this is a real opportunity to, as Dr. McLaughlin David commented, use innovation to advance the translational science. And how do we measure community impact? How do we design prospective studies that are patient-centered in a sense of empowering patients with passports and with other things as citizen scientists in designing the research that we can go next. So just a quick thought on translational science as we wrap up our time together, and other thoughts from the panel.
Sean, in my concluding thoughts, I just want to provide some data that we came across last year at our institution, and leave this as a challenge for the group to understand how we could solve this. So we made the comment a number of times that these data are true for your lifetime. So what does that actually mean? Well, we've built a clinical decision support system that uses discrete data that are in our medical record. And when patients prescribe certain medications, alerts trigger. It's one of many tools that we use. There were 2 patients in 2024 that they triggered an alert for the first time in their history of having results for behavioral health medications. How long did they have those results in their system? These two patients had testing done more than 6 years ago. Luckily the system worked. We pulled data more than 6 years old to inform their treatment. That only worked because these were not transient patients. Had they been socially disadvantaged patients that were more likely to be transient or been somewhere else, they would have missed out on the benefit of having this data because we don't have the right tools to empower patients to take care of themselves in the best possible way. As a community, we got to solve that.
Yeah.
And that's the only way that genomic medicine is going to make a difference. Only when patients can realize and drive the value of genomic data will it matter. Otherwise, we're just testing to test, and that's a waste of time.
Thank you. That's a powerful challenge, and it makes it real because we as a primary care physician, I know that sometimes we lose a lot of patients that don't come back, and if we don't catch them when we can, and activate them, find a way to do that, then all this innovation isn't going to do any good for society. So thanks for that challenge, Dr. Dunneberger, and I'd like to thank the whole panel, Dr. Flaniapan, Dr. Pereira, Dr. Dunneberger, Dr. Saulsberry, for a really a brilliant and evocative talk. Thank you so much. And we will go on to my counterpart, Rachel, for some information about the evaluation process. Rachel.
Thank you again, everyone. Thank you very much for joining us today. For questions, comments, concerns, or requests to present at future seminars, please contact Dr. David, whose email will be listed on this slide. If you could all take a brief survey regarding today's presentation, it would be really appreciated. You will be directed to a site after you close out of the window, and the link is also in the chat box. I will put it in the chat box as soon as I'm finished with closing out for the day. Join us for our next seminar on Tuesday, April 18th, where we'll dive into ITM Sociome Data Commons 2 with Dr. Carlos Santos from Rush as our featured speaker. And again, thank you very much. I will get this information for all of you in the chat. Just one moment. Yeah.
Well, thank you. I mean, just to summarize, this group of investigators and health system leaders has really been at the forefront of advancing health equity through genomics, and there's clearly several innovation challenges ahead of us. So hopefully we can continue to have more to talk about the next time we get together, because I think that there's a great opportunity here with community partnerships that we've developed in Chicagoland, for example, to try to develop this work and learn from the community. So thank you all so much, and have a safe and happy rest of the week.
Thanks, everyone.
Thank you.